Module 16L on shock. So, first slide. Hemostatic regulation. That's where we need to start before we actually talk about shock. And, what is it? It is the regulating our oxygen applied to our cells and removing metabolic waste. That's how our body keeps itself stable. It does this through your cardiac output that has to meet our bodily requirements. Compromised vascular system. So our heart has to sufficiently pump out the oxygen to get the blood to get the oxygen, nutrients, everything our body needs to the heart, to our whole body. We just finished the whole perfusion, all these systems in the heart. Uncompromised vascular system because we need to not have a lot of resistance in our lungs, in our periphery. When the heart is pumping out everything, we need our kidneys to be sufficient blood flow through them. We need our endothelial tissue not to be impaired where it's leaking through. Blood volume sufficient to fill circulatory system. Absolutely. If you don't have enough volume, your output and your cardiac index, all those things drop and we have decreased perfusion. Blood pressure adequate for blood flow. It needs to have enough pump out there to get it going through. Think of your old what we talked about with CHF, or cardiac output perfusion, the Frank Starling law. Okay, tissues able to extract and use oxygen delivered through capillaries. That's tissues all over your body, including your lungs. We talked about with the lungs, with like pulmonary edema and pulmonary embolism, and when we talked about sepsis, it's at that capillary bed ending where things are diffusing and the oxygen, the carbon dioxide is being pulled out. So all those capillary endings where the final stuff is taking place has to be functional. Okay, so what is shock? I broke it up from your text on page 1307. Systemic imbalance between oxygen supply and demand. Inadequate blood flow to body organs and tissues. Life-threatening cellular dysfunction. It is a syndrome characterized by decreased blood flow to the organs and tissues. That's simple. It results in inadequate oxygenation, and then there's a cellular level life-threatening dysfunction. It is widespread reduction in tissue perfusion. So there's an imbalance between your oxygen supply and your oxygen demand. When that happens, we end up with anaerobic metabolism with lactic acidosis because of the working without oxygen. We build up those acids so the cells in the organs cannot function like they need to. Our metabolic state gets out of whack. The longer that happens, the more cellular death there is, multi-organ system damage, and then death of the individual. Etiology of shock. Caused by any condition that reduces blood flow. Any condition. Any component in our hemostatic regulation that we discussed that is off. Anything in cardiovascular that compromises our hemostatic state. If the tissue perfusion cannot maintain normal cellular metabolism, and shock is triggered by a sustained drop in mean arterial pressure, which we talked about several times, your MAP being less than 60-65, in that range. Okay, this was just a good little picture I found on mean arterial pressure and shock. It just did a good job breaking up the early compensatory, progressive signs, and refractory. So in the early, your mean arterial pressure drops slightly, maybe about less than 10. So let's give you an example. Okay, so I mentioned in talking about sepsis and getting into shock that The blood pressure may not drop initially, or they may, no, that's not what I said. May not be hypotensive. That doesn't mean the blood pressure doesn't drop. So, with our early signs, a mean of about 10 or less than 10. So, you have a person whose blood pressure is, they're fine, and their blood pressure is 120, say 120 over 70. That's a mean arterial pressure of 86. Then their blood pressure drops to 110 over 60. Not significant, 120 over 70 to 110 over 60. Not significant drop, but their mean arterial pressure has dropped to 77 or 76.8, rounding to 77. So it's under 10, but it is a drop, and it is the early sign that they're in trouble. Then you get to where the body tries to compensate, but your mean arterial pressure is now dropping 10 to 15 from their baseline. So they're running like 108 over 60, 100 over 60. So they're between 10 to 15 millimeters of mercury drop in their baseline pressure. Just like when we talked about in heart failure and your ADH, antidiuretic hormone, your renin levels, your body starts to say, wow, I need to hang on to what volume I have. So your posterior pituitary is releasing those hormones and hanging on to that antidiuretic hormone, hanging on to what volume it can. And it's trying to compensate. It says, wow, I need to hang on to fluid. I need to constrict things. So your pulse pressure is going down. Do you remember your pulse pressure is the difference between your systolic and diastolic? So instead of being 110 or 120 over 70, you get a narrowing pulse pressure where you're maybe 120 over 70, or you're 110 over, I'm sorry, we were 110 over 60, 108 over 60 when you're getting in trouble. 110 over 60, all of a sudden we're 100 over 60, 90 over 60, a lessening pulse pressure. And think about it, that narrowing pulse pressure makes sense. It can go either way, your systolic coming down, your diastolic staying the same, or going up. Why would that happen? You're systolic. Your ventricles are pumping out. If you have less volume, they're going to have less to pump out, so your systolic is going to go down. If there's vasoconstricting, your body's tightening up its periphery, it's tightening it, then your resistance is going to go up. Your vessels aren't relaxed, so your diastolic resting number is higher. So that's your narrowing. That's your body trying to compensate. Then you get to where your body says, wow, I'm not doing so good. I'm decompensating. This one calls it progressive signs. Your text calls it decompensation. Your text also uses a class 1, 2, 3, which I'm not familiar with. So I'm going with early, compensatory, decompensated, and refractory instead of the classes they use. So we're at what your text called class 3 or decompensated shock. This picture calls progressive. I like decompensated because it's when your body is wearing out. This is when you sustain a decrease in your mean arterial pressure 20. So just look at your progression. Around 10, 10 to 15, down to 20. It's progressive. It's worse. Your mean arterial pressure is in the gutter. It can be 20 or more. And you have no volume. Your fluid loss is 30 to 50%. You are in trouble. So your tissue organ hypoxia, oliguria, maybe anuria, because your kidneys have no volume to pee out. Your body has used up everything, trying to tighten everything here, and it's out. Your weak rapid pulse, because again you're beating really hard to pump around, but there's nothing to pump. Your pH is dropping as well. It starts to drop here. You start to get acidotic. It might be respiratory, it may be metabolic, but by the time you're in here, you're getting in multiple system and you may be acidotic both ways. Central neural changes, of course, because you have decreased tissue perfusion, hypoxia, nothing's getting to that brain, you are confused. Lactic acid is forming, that's that acidotic because it's breaking down everything because of anaerobic metabolism. Your cells are swelling because they're leaking. Heart rate just keeps going up because your body's constricting more and more and more in its last ditch attempts to perfuse the vital central system. With acidosis, your potassium starts to climb. You got hyperkalemia, which is making things worse, and chances of survival are really poor. Then you get to the last one, what your text called class 4, your refractory. That's when generalized anoxia, no oxygen to the body, there's cellular death, multi-system organ failure, nothing can reverse this, and they are going to die. It doesn't mean they're dead right now, but there's nothing to reverse, and it's a matter of time, and they are going to die. Okay, so let's look at the general body system effects of shock. Cardiovascular. Some of these slides I remember to put your page number on. Some of the slides I forgot. But if you want to follow in your text, it should follow along pretty well. I did put page 1309 here in your Pearson. Okay, so cardiovascular, myocardial cell hypoxia, because your heart cannot pump like it was. So lack of oxygen is getting to the heart cells. The heart muscle function is less for multiple reasons, but as hypoxia goes to those heart muscles, less oxygen, it's going to function even worse. It's very common for the heart rate to be very elevated, 120 or higher, because you have vasoconstriction and pressures, and the body's just trying. Even though it's pumping fast, it's going to be weak and thready because there is no pump behind it. There is no squeeze, there is no volume. Altered acid-base balance, that hypoxia, lack of oxygen, elevated potassium, because where body is functioning in a hypoxic state, it's anaerobic metabolism. Of course, with all this hyperkalemic acidosis, hypoxia, you're going to have different kind of dysrhythmias. Blood pressure keeps falling. You have to monitor the hemodynamic state. Blood pressure, pulse strength, CVP. Okay, your respiratory system. There's impaired gas exchange, increased carbon dioxide levels leading to respiratory acidosis, acute respiratory distress syndrome, or shock lungs. Their respiratory rate goes up even though their alveoli are not being perfused, as we talked about with pulmonary edema, pulmonary embolism. If you remember that, at that alveolar capillary exchange level, it's not happening. So you're breathing faster, the body's trying its best, but there's no exchange taking place. Your GI system. Constrict splenic arterioles, GI organs become ischemic, irreversible damaged. Normally, your GI system receives 25% of your cardiac output. But when the body starts getting in shock, the last thing it wants to perfuse is waste 25% of its output on the gut. It says, I don't need the gut. I need my brain, I need my heart, I need my lungs, and I need my kidneys. So you know what, gut, you just need to stop. So it constricts. As it constricts, it's not, peristalsis is not happening, oxygen's not happening, there's acidosis because the metabolic acidosis starts to set in. Stress ulcers can develop, they can hemorrhage within 2 days to a week. Within the onset of shock, they can start having gastric GI bleeding. And then bacteria starts to build in the abdominal cavity, just worsening the sepsis. They can get paralytic ileus, where you have a bowel necrosis, which again leads to more sepsis. Your liver is not perfusing, your liver is starting to die. It is just your liver enzymes are going up. The liver can no longer remove that lactic acid that's happening from anaerobic metabolism, and you get the metabolic acidosis. Neurological. Change in mental status, orientation, apathy, lethargy, coma. In the beginning, it's restlessness as hypoxia starts to set into the brain. As it gets worse, mental status changes. There's hypotension, so you're not perfusing to it. The faster your heart's going, the tachycardia, you have more cerebral ischemia. You have systemic vasodilation, the blood is pooling in the periphery. It's less and less is getting to your vital systems. Your renal system, those kidneys that we need so much. The blood is shunted to the heart of the brain. Initially, first it cuts the gut. Then it starts cutting the kidneys, trying to keep the brain going and the heart going. Oliguria, the urine is decreasing into greasing until it becomes anuric. The urine is more and more concentrated. It gets to the point where it's not doing anything. Tubular necrosis, because there's no perfusion to the tubules in your kidneys, in your nephrons, and you go into acute renal failure. Tubular necrosis occurs when there's a drop in perfusion for 30 minutes, which is going to happen in shock. It's not a total cutoff, but that drop in that perfusion for 30 minutes starts tubular necrosis and leads to the renal failure. The renal failure can become permanent. So even if they manage to recover from a shock, they may not regain all their kidney function. The effects on the skin, temperature, and thirst. Remember, your skin is constricting, so it activates the sweat glands. So you have a diaphoresis until the point the patient has no more fluid to diaphoresis, but your skin color is white, very pale because it's not perfusing. If it's a dark skinned person, you're looking at their lips, oral mucosa, nail beds, conjunctiva for this paleness. I said that moisture is because of that activated sweat glands from vasoconstriction, drop in body temperature, later shocks, stages of shock are edema, because that's when you start that third space when the vascular is so impaired that it's leaking out. Increased thirst, because the body is just saying, please, I need volume. So if we look at all these body systems, we put it all together. Body's trying to compensate by tachycardia, increased respirations, decreased urine output, the diaphoresis, the drop in systolic blood pressure, narrowing pulse pressure, decreased level of consciousness, and they go into a cardiopulmonary failure. So there's different types of shock. Hypovolemic, cardiogenic, obstructive, distributive. Those are the basic categories which are going to make sense when I go through them here. Let's start with hypovolemic, since it is the most common type of shock. If there is a decrease here of your volume, intravascular volume, for multiple reasons, but a decrease of 15% of a vascular volume, you can go into a hypovolemic shock. It'll affect all your body systems. Multiple reasons: hemorrhaging, intravascular fluid from the skin, somebody getting so dehydrated, gross diaphoresis, severe dehydration, significant diarrhea, vomiting, suctioning, whether it's significant, severe onset, or it's for a prolonged period of time. Like you'll see a patient has an NG tube into low continuous suction and no volumes being put back in. What do you think is happening? We're sucking volume out of them. Diuretic use, diabetes insipidus that we've studied before, fluid shifts where you're going into this third spacing. So even though there's fluid on board, it is outside of the intravascular space. It's in the extra outside of the vascular. Body can't use it. It's in intracellular. Okay, so there's a decrease in blood return to the heart. There's a decrease in ventricular filling. A person's age, their general state of health prior to this incident, how bad the injury or illness is, how much time before they started getting treatment, the rate that they're losing their volume, all impact how they're going to, how rapidly they're going to progress and whether they're going to recover. Pathophysiology of hypovolemic shock. This was a slide I found that's just very helpful. It also talks about this in your text on page 1314. Decreased volume return, so there's a decreased preload, which is a decreased cardiac output, which leads to low blood pressure, decreased perfusion, tissue hypoxia, organ dysfunction, multi-organ failure. That's total sense. Remember the hypovolemic if you have a volume loss of 15% or more. And it's the most common type of shock. Okay, let's talk about cardiogenic shock. Cardiogenic, heart. It's the inability of the heart to maintain cardiac output necessary to meet body needs. Again, I found this on Pinterest. It was just a great little picture showing your systolic, diastolic dysfunction, arrhythmia, structural problems, all can cause this. My next slide, I go in more in the causes. So we're looking at what cardiogenic shock is. Decrease in cardiac output. That leads to the decrease in mean arterial pressure. Cyanosis is common. Left ventricular end diastolic pressure increases. Left ventricular end diastolic pressure increases. So the left side of your heart, the end diastolic pressure. So the amount of pressure that is, okay, hang on. Okay, so this is what we talked about with your diastolic failure, diastolic heart failure, diastolic dysfunction. Your left ventricle isn't able to squeeze well. It has a decrease in compliance, decrease in its ability to relax. So, of course, then it's backing up into your lungs. And then you have right heart blood retention leading to jugular vein distension. So there's a chance of having pulmonary edema when this is backing up. So causes of cardiogenic shock. This is page 1314 in your text. Oh, no, sorry. I think that's what page it is. Anyway, your causes, anything, pump failure. So cardiogenic shock is pump failure. It's when your heart fails to pump adequately, whether it's right-sided, left-sided, both-sided. Myocardial infarction is the most common cause. Often it's what they call a left main stem infarct. The blood vessel is that left coronary artery is, they call the widowmaker. So anyway, myocardial infarction is the most common cause for the heart to fail, pump failure, cardiogenic shock. Cardiac tamponade, when the sac around the heart has blood and it's tamponading, it's squeezing the heart so the heart cannot function. Restrictive pericarditis, again, the sac becomes inflamed and it restricts the ability of the heart to squeeze and pump. Cardiac arrest, obviously, because it's not pumping at all. Dysrhythmias. We've just talked about all those different rhythm things and how that impairs your cardiac output and perfusion. Valve pathology. Any of the valves going wrong is going to affect all the flow in the heart and lead to other issues. Cardiomyopathies, complications of cardiac surgery, electrolyte imbalance, drugs, even head injuries. All these things can lead to a pump failure where your heart is no longer functioning right. So cardiogenic shock, anything that causes pump failure. Okay. Next is your obstructive shock. The third type of shock is due to an obstruction in the heart or great vessel. Anything that impedes venous return or prevents effective cardiac pumping. Obstructive. So I broke this up for you to help you. Blocked outflow from the heart, massive pulmonary embolus, aortic dissection, cardiac tamponade tension pneumothorax. The blood cannot leave the heart. It's obstructive. Obstruction of venous return to the heart, vena cava syndrome, which is usually a neoplasm in the thorax, or sickle cell, obstruction of spleen by sickle cells. So think about your hepatic circulation and your spleen, and you have these sickle cells. They're shaped like sickles, so they obstruct and they cause an obstruction and splenomegaly, and it backs up and causes pressure, and so things are not returning to the right side of the heart. Obstruction of venous return. So the heart is still working, but there's a problem with the blood flow coming out of the heart or going into the heart. Obstructive shock. This was a good little picture I found of obstructive shock. Leads to impaired diastolic filling, increased right ventricular afterload, increased left ventricular afterload. This shows as a decreased cardiac output and blood pressure. So if it doesn't fill, impaired diastolic filling, so when the ventricles are relaxed and they should be filling, it's impaired because there's an obstruction of the volume coming in. Increased right ventricular afterload. So after the ventricles squeeze to pump out, they haven't pumped completely, so there's an increase in afterload. Not all the blood pumped out of that ventricle. So I have an increased right or increased left, or it could be increased on both sides. So anything is going to decrease your perfusion, mess with your cellular metabolism, and worsen your signs of shock. So this little picture has you go around and around with what's happening with this obstruction and leading to shock. The last type of shock is distributive shock, vasogenic. It's a type of shock due to widespread vasodilation and decreased systemic vascular resistance. Of course, if you vasodilate widespread, there is less resistance in the vasculature because it relaxes. There is no change in their blood volume as in obstructive hemovolemic or cardiogenic. There is plenty of there, but it is so vasodilated that it decreases perfusion and leads to shock. So shock, distributive shock or vasogenic shock, the types are septic, neurogenic, anaphylactic. Neurogenic results of imbalance between parasympathetic and sympathetic stimulation of vascular smooth muscle. That's your nervous system. Imbalance between your parasympathetic and sympathetic nervous system, neurogenic shock. Sustained vasodilation. Remember, this is a type of distributive shock. The distribution, gross vasodilation. Reduction in systemic vascular resistance. So head injury, spinal cord injury, insulin reaction, central nervous system depression, drugs, anesthesia, severe pain, prolonged exposure to heat. Anything that is going to affect that nervous system and an imbalance between the sympathetic and parasympathetic. I'm not going to talk about septic because we just talked about sepsis and septic shock. There is, remember, septic shock, the whole system is not functioning right, but they don't lose volume. And the last one is anaphylactic shock. a result of widespread hypersensitivity reaction. Vasodilation, pooling of blood in periphery, leading to hypovolemic. It looks like a hypovolemic state, although they don't have less volume. There's less volume seems to be circulating because they're so dilated. It occurs in contact with an allergen, medications, blood administration, latex reaction, food, snake venom, insect bites. And the clinical manifestations. Okay, your clinical manifestations. These are just clinical manifestations of shock, not any certain type of shock. Now the rest is just generalized shock. Onset may be rapid or slow, depending on the cause and severity, obviously. Signs of early shock may be nonspecific, and we talked about that. When we talked about sepsis, as body compensates for hypotension, hypovolemia, and the signs of shock, we get tachycardia, increased respiratory effort, decreased urine output, diaphoresis. We talked about the different stages, so let me go back to my notes with your stages. Renal system stages. Okay, yeah, so on slide 5, your early shock. So your compensatory shock is where your body there with the hypotension, hypovolemia. And if treatment isn't begun, the drop in systolic pressure continues, the narrowing pulse pressure, reduced cerebral flow, decreased level of consciousness, progression to cardiopulmonary failure and death. So this is just summarizing what we just talked about. Your manifestations are going to be everything we talked about. Then your diagnostics. Just like with sepsis, if you look at it, not necessarily WBC, but your hemoglobin, hematocrit, blood gases, electrolytes, BUN creatinine, specific gravity. Here you're looking at blood cultures because is it sepsis? I guess I don't know that I mentioned blood cultures, white blood count and differential in your sepsis, because those should be part of that because what is growing. And anytime you're doing a sepsis workup, you never assume, because what if there's more than one component going on at the same time? Serum cardiac enzymes because of looking for cardiogenic. And it central venous catheterization, so you can get your volumes within your heart to figure out what's happening. Other tests that might include X-rays, CAT scans, MRIs, endoscopic echocardiogram, depending on what the patient is demonstrating, what might be going on in the body. Okay. Pharmacology. Again, not that there's specific questions on this exam. All these drugs have been covered in your pharmacology courses. So we talked about your vasopressors, inotropes, vasodilators, colloids when we talked about sepsis. So you want your inotropes to get your squeeze with your dopamine, dobutamine. You might hang isopril. Your vasoconstrictors, vasopressors when that blood pressure is in the gutter, norepi, epi, phenylephrine. Not sure if you remember from when we were out at Motlow with the sepsis awareness. Your norepi is your Levophed, and your phenylephrine is neosynephrine. But your norepi, Levophed, that's one of them had been around a while and mentioned, like I remembered, Levophed, leave them dead is what we used to say with when we got to the point of needing to hang Levophed. We felt like, okay, if we're hanging Levophed, they're dead. But that is now not the thought process. We've learned so much more, and the earlier hanging that Levophed and trying to get that perfusion going, the better. So your colloids are, remember, crystalloids are your IV fluids, colloids are your blood products, albumin, hepastarch, which they've really, I don't think, used that anymore. Your blood products might be Pac cells, whole blood, which you really don't see, but Pac cells, PRBCs,
cryoprecipitates, fresh frozen platelets, depending on what's happening. Other drugs, diuretics, sodium bicarb, not used often, calcium, antiarrhythmics, might be calcium channel blockers, broad spectrum antibiotics, epi, antihistamines, beta blockers, morphine, anything that is needed for whatever the situation that's going on with this person is. Interventions. Same as your sepsis. Oxygen therapy, fluid replacement. Oxygen therapy, fluid replacement. You want to treat the underlying cause of the shock while you're increasing oxygenation, improving tissue perfusion. So we talked about what labs you're looking at, what imaging you might be doing. Everyone in any shock is going to be on a form of supplemental oxygen, whether it's a cannula, a mask, an intubation. You want to maintain their arterial O2, PaO2 greater than 80 millimeters of mercury during the first 4 to 6 hours of care. So throw that oxygen on them. Ventilator assistance may be needed if they're unable to maintain that oxygenation. Shock in older adults. They may not present the same and they're more at risk for poor outcomes. They have a decreased sympathetic activity, so your nervous system doesn't kick in as fast. They might not have any cardiac reserve or compliance to increase these volumes. Much more sensitive to hypovolemia. Remember, their skin is fragile, losing fluids, their vascular is fragile, and they may be on the lower hypovolemic state to start with, and they are more likely to have multiple comorbidities. Aggressive fluid management may not be possible for the older adults, especially if they're cardiac decompensated, and then you're going to put them in a fluid overload because they can't pump it out. And if they end up on the ventilator, the chances of them dying are higher due to complications, pneumonias, and other things. Okay, so your assessment. I decided to make this slide to help you see this because reading in your text was a little difficult. Look at this and think about it. What are you assessing for? What kind of shock? So if you're a hypovolemic shock, did they recently have surgery, multiple traumatic injuries, serious burns? If they're cardiogenic, you're looking for cardiogenic pump failure, most often left anterior wall MI, most often, but anything that is decreasing the ability of the heart to pump can lead to cardiogenic shock. Neurogenic shock, something that is causing an imbalance between the sympathetic and parasympathetic nervous systems, most commonly a spinal cord injury or maybe from spinal anesthesia. Anaphylactic, is there an allergy to something, a drug reaction? Is it even a blood transfusion reaction? Septic shock, more common if they're hospitalized or debilitated, chronically ill, have undergone invasive procedures, and maybe all of the above, which puts them at great risk. Diagnosis and goals. So what are you doing as a nurse? Obviously, a shock is a decreased cardiac output, so that's a diagnosis. Ineffective tissue perfusion, anxiety is going to go with it, with the hypoxia of the brain, the breathing, the whole thing. What can you do as a nurse? You're going to maintain airway, breathing, circulation, the ABCs. To do that, you have to maintain perfusion. You have to reduce their cardiac workload. You have to help them express their feelings, the family, give them explain procedures, things that are going to happen in them to again decrease anxiety. What's your action plan? What can you do as a nurse? Get the IV access, prepare fluid administration, calculate what's needed, administer the meds, IV push the fluids as rapidly as ordered and the patient can tolerate, closely monitoring their response, getting ready, always being ready to give more. If you have a system there where you can warm the fluids during that initial resuscitation, that is better. and continuously assessing their circulatory response, which is your whole assessment. Okay, you want to preserve their cardiac output, assess and monitor cardiovascular function, baseline assessment to establish stage of shock, because you need to know where they were, where they are to know how bad they are, and where you need to get them back to. You're monitoring their INO, bowel sounds, distension, looking for chest pain, dyspnea, bed rest. So your IV access, preparing your fluids, watching their blood pressure, heart rate, pulses, hemodynamics, or their O2 saturation. And doing everything you can, like here with bed rest or minimal activity, not to exhaust them. Promote tissue perfusion. Their skin color, turgor, this is everything you're assessing. You're again watching their blood pressure, respirations, lung sounds, pulse oximetry. You're assessing their peripheral pulses, looking for jugular vein distension, their CVPs, their body temperature, making sure they're warm enough, not too hot. The mental status, because they perfusing everything in their body. And relieving their anxiety. What measures can you take? Administering pain medication. Morphine is a good one. Patient and family support, increasing their comfort and reducing their restlessness. You want to give them a clean environment. You want to do good skin care, oral care for comfort and for protection. Eliminate non-essential activities. That's going to preserve the cardiac output. And your skin care is going to help with your tissue perfusion and also preserving non-essential activities. Remain with patient during procedures, speaking slowly, calmly, short sentences, touching them as appropriate, because it helps with the comfort and decreasing anxiety. Our last slide, evaluation. You want to evaluate that you are maintaining adequate oxygenation, adequate urinary output. Watch to see if they're going into an uncompensated shock, and helping with the family and the patient dealing with everything that's going on. So everything comes full circle, and that is the end of my lecture on shock.